Good afternoon, and many thanks for joining us for another special take on Cleveland Clinic's response to COVID-19. My name is Laura Kalafatis, and I'm the chair of the Philanthropy Institute at Cleveland Clinic. I'd like to extend a warm welcome to everyone on the call and on our Zoom, supporters across the United States and around the world, as our friends from the business community and our donors. We hope you and your loved ones are staying well. We begin by acknowledging our true heroes among us, the doctors, nurses, and other caregivers on the front lines of this crisis. Their courage and compassion continue to inspire all of us, and we thank them from the bottom of our hearts. Our guests today are Dr. Serpil Ezram and Dr. Lisa Urian. Dr. Ezram is the chair of Cleveland Clinic's Lerner Research Institute. There, she oversees one of the leading research institutes in the nation, with 1,500 scientists and support personnel in 190 laboratories. Dr. Ezram also is a practicing and highly accomplished pulmonologist. She holds the Alfred Lerner Memorial Chair in Innovation Biomedical Research, and her work has advanced diagnoses and therapeutics for various lung diseases. Dr. Urian is the Chief Improvement Officer here at Cleveland Clinic. She joined the staff in 2004 as a gastrointestinal and liver pathologist. 6 years later, she was appointed Medical Director of Continuous Improvement. Her drive for efficiency has changed our health system's culture and led to the development of Cleveland Clinic Improvement Model. Dr. Urian is a member of Cleveland Clinic's team that is advising employers on how to reopen businesses safely and successfully during this pandemic. Before we proceed, a quick programming note. Dr. Jim Merlino, the Chief Clinical Transformation Officer at Cleveland Clinic, was scheduled to be on our call today. Unfortunately, the clinic has not discovered teleporting just yet. So as we speak, Dr. Merlino is attending a press conference to discuss the Cleveland Clinic's efforts on behalf of helping businesses reopen. In addition, if you have any questions and are on our Zoom link, please just click the Q&A button. For those on the phone, we've tried to capture your questions in advance. So let's get to it. This is a timely topic of our new normal, and we're delighted to welcome Dr. Ezram and Dr. Urian, who've been actively engaged in our Cleveland Clinic at Work efforts. Thank you both so much for being here today. First and foremost, I'll start with you, Dr. Ezram. Welcome back, and how are you and your family?
Thanks so much, Laura. We're doing well as we move into this research restart, and with my family being able to go out more. So thanks, we're getting there.
Good. And Dr. Urian, welcome. And
thank you so much. We're great. Thank you so much for having me today, Laura. I really appreciate the opportunity. My family as well, I think, adapting to the new normal and dealing with challenges as well as looking for the bright spots and enjoying the summer as best we can.
Yes, well, I'm glad, as we are in this new normal phase, what does that look like for you? Not just your family, but your work. Can you describe that?
That's a great question. I would say much more of my work is accomplished virtually. So whereas before I would have quickly walked into somebody's office, walked into a meeting room, I do much, much more communication, collaboration, and teamwork online or over the telephone. I would also say that much more of my work is, of course, focused on COVID. So my team's been heavily involved in our COVID response and then subsequently our reactivation efforts. So we helped with creation of the drive-through testing sites in Ohio and in Florida. We helped with developing the surge plans. How do we develop spaces and processes for our teams to deliver care to patients if we had a COVID surge? And now with the reactivation, how do we ensure that our facilities and our teams are prepared to safely bring patients back so that they could come in and receive the care that may have been postponed due to the COVID epidemic?
So when you really think about continuous improvement, you were on hyperdrive of creating what that would look like during COVID, and now I would say living with COVID and working with COVID.
I agree, although tragic for many people, it really is the perfect opportunity to leverage our skills as we look to build new processes that we need to implement in order to respond to COVID and keep our caregivers and our patients safe, but also very quickly improve those processes, standardize them, and really begin to share them throughout the Cleveland Clinic and also with other organizations, which is what we're trying to do at this time.
We'll get back to what that looks like for our patients and for our caregivers. But Dr. Ezram, I'd like to talk to you a little bit about the new normal, not only for your family, but for research and the research priorities of this new normal for you and your colleagues.
Well, we've, as you know, started a lot of COVID research just over the last 2 to 3 months. So part of the research restart is not just getting back to the research we've done, the impact areas that we've defined for us to be important for our patients, but now the new coronavirus. And so we've really been working hard to develop the teams across the enterprise so that we can do the best research possible and accelerate ideas for vaccines and therapies.
Excellent. Our understanding of coronavirus continues to evolve. What do we know about it today that we didn't even know a few weeks ago? And maybe Dr. Ezram, you can respond to that.
Oh, there's been an exponentially growing body of literature on this new coronavirus, which is the SARS-CoV-2 that causes COVID-19. Papers coming out, multiple papers every day about the virus itself, how it infects, what it does within the cell, how it reproduces, how it infects others, and about our host, the individual infected, the host response, the immune system that we have, how it responds to the virus. And now we're getting into how the host response varies across demographics of gender, race, and age, and comorbidities important to us and our patients that we care for. People who have heart disease, high blood pressure, asthma, cancer, all those things now we're starting to study susceptibility and the resilience that seems to exist in some people against that virus.
And I'd love for you to expand upon that more. I think early on when we talked about this, we were saying that it had no boundaries in terms of race or age or geographic location. Are you seeing any patterns in some of the research, and what are we learning from the research that's currently going on?
So we have established with Laura Jehai and Mike Catan a COVID registry across the enterprise. And this is for us to understand just the questions you're asking. Who and where are people affected? How is it transmitted? What makes you susceptible or resistant? And so we've started to learn that there is a susceptibility of individuals over 65, that there is a racial susceptibility in our minority African American community, that individuals with diabetes and cancer seem to be particularly at risk. These are the kind of questions that we've focused on as we begin to care for and return to our regular care as the governor has opened Ohio so that we can provide the safest care for everybody as they come here and do our research.
It's great. I feel like I have a double header here. It is baseball season without baseball. And Dr. Ezram, you're talking about the research and you're talking about the virus. And Dr. Urian, I'd love for you to speak on how we're treating COVID and what we've done to see in terms of the treatment as what we've learned over the course of this period and how we're treating COVID-19.
Yeah, so thank you, Laura. We very quickly put into place a process for patients who were symptomatic to reach out, contact a provider, and get a prescription in order for testing so that they could get tested without having to come into the clinic or to the hospital, without having to come into the emergency departments if they weren't severely ill, but still get tested in a safe way. So they were able to do that with our Express Care Online, really by making a simple phone call or virtual visit to get that care. If patients are symptomatic, we're able to do testing. So we're offering testing. Currently, we have both the routine test and the rapid test. And then for those patients who are well enough to stay at home, we're able to keep them at home, providing care virtually through a care companion tool. So we will monitor patients' symptoms at home and then contact them, reach out to them if we see that they're becoming more ill. And in that way, be able to support them while they're able to stay at home. But if they are in a position where they've become ill enough that they need to seek acute care, bring them in so that they can see a provider. And then we'll, of course, admit patients into our facility and provide care as needed needed and as appropriate going forward.
What is a care companion tool? Can you describe
Yeah,
that
it's
a bit?
actually, it's very cool. It is.
Sounds like an avatar.
It is in many ways like that. It's basically an app
Uh-huh.
that is integrated with our electronic medical record that connects with you and enables you to track your symptoms today. So it will ask you, what is your temperature today? Are you running a fever? How are your symptoms? How's your cough? Is it getting worse? Is it getting better? Do you have shortness of breath? And then a nurse can see the information that you've uploaded on your app and see, oh, this patient is doing well, this patient is getting better, this patient's getting worse, and then selectively decide what is the contact that you need and what is the care we need to provide for you based on the information you're entering for us. So we've had thousands of patients engage in this system, and it's been a very effective way for us to help take care of a large population of people who really need to be distanced because of the infectious nature of their disease.
Wow, sounds like an application that could be used for a lot of purposes beyond COVID.
Yes, we think it has a ton of potential for helping our patients.
I'd like to get back to you, Dr. Ezram, and maybe both of you can talk. You mentioned testing. Testing remains at the top of the list. Can you talk a little bit about our evolution of testing and where that's headed? Because many people want to get tested. We hear from people all the time who maybe are asymptomatic, but just feel for assurance purposes that they would like to be tested. What's the best answer for that?
Well, testing has been top of our mind since this started. And I'm so proud to work with my colleagues in pathology like Lisa, because Cleveland Clinic was one of the first places to get testing set up and moving forward for our population here in Cleveland. And across the nation, there's been a real lag in some places for testing. So testing, again, Lisa, you should correct me if I'm wrong, but testing is really interesting. I've done some work in this area. The gold standard really is a molecular test. Now, that's a test at one point in time. An individual comes in, just as Lisa suggested, if they're symptomatic, they go to a site. You've seen this nasal swab they put into the back of your nasopharynx, way back in the back of your nose. That's where the virus likes to live and replicate, make more of itself. In a person who comes in that has the virus actively, when we swab that area, we will collect the virus particles. The virus has a nucleic acid called RNA. Take that back to the lab. We're able to amplify that and then look at it and sequence and or probe it. And we know for sure that it's SARS-CoV-2. That's the gold standard. You have a virus in the back of your nose that is SARS-CoV-2. Now, you could have that test. You could go home that night, have friends over, and get infected. Testing at one point in time does not guarantee that you will not get it a day, a week, or a month later. Testing is really important for public health purposes. If you are positive for a test, we then follow up with all your contacts. We want to stop the virus in its tracks. Over the last 3 to 5 days, we will track who you were with, who might have been exposed, and test all them because they might be pre-symptomatic, asymptomatic, they could be spreading the virus. So that's the public health component of testing. That is what we keep hearing about in the news. And of course, the Cleveland Clinic is advocating this very solid approach for the care of our patients and the community.
Thank you. And testing is limited. There's only so much in terms of the capacity. Lisa, do you want to talk about, how we're triaging, I guess, the testing capabilities?
Yeah, happy to. And I just will reiterate what Serpil said. The Cleveland Clinic was really an early leader in developing testing. So we were one of the first laboratories to develop the ability to do the molecular tests that Serpil just described. And we also opened one of the first drive-through testing sites in our region here in Walker, the Walker Center. And that's important because with a drive-through facility, you're able to keep patients in their cars so they're not out touching things, potentially exposing each other or our caregivers who are performing the testing to getting the infection. We started early on in March with the drive-through testing site, testing symptomatic patients and caregivers. And we continue to do that testing here at Walker and in several other facilities in Ohio, locations in Ohio, and also within Florida. We also, of course, test patients coming in the emergency department or patients admitted to our hospital. We also, as we started to reactivate to perform surgeries and procedures on patients who don't have COVID that were not emergent, we developed a strategy to test those who would be in a position to expose others. So we now have implemented testing for all patients coming in for a surgical procedure within an operating room at 3 days prior to having that procedure. So I'll remind you, as Serpil said, that if we get a test, it's really a point in time. So if I test you in 2 weeks, you might have gotten the virus. So we're trying to allow enough time to get the results, but really shorten the time to reduce the risk that you're getting that infection between the time we do the test and the time you come in for your procedure to ensure that you are safe and well prepared for this care.
So you described the gold standard of tests, but there's a lot out there about antibody testing. So who would like to take the question of antibody testing, and why is the Cleveland Clinic currently not doing antibody testing?
So antibody testing is when we take blood from the individual, we look at the serum, and we use tests to identify immunoglobulins, those are antibodies, that are specific for a microbe. So we use antibody testing in convalescent serum, but there are major limitations for an antibody test for diagnosis of COVID. And I think that's what people really want to know. Have I had COVID and have I recovered? So let me go through that process. So if we were to draw blood work to get immunoglobulins from somebody who was diagnosed with the molecular gold standard test, and I looked at antibodies, and this has been done, we would find that most people, if not all people, depending upon the levels of antibodies, that yeah, they had developed antibodies. And if we look, it would look like there were binding and neutralizing antibodies against the virus. So then that comes to the question, why can't we just do that antibody test? Well, there are a couple issues. First of all, our tests for immunoglobulins are not specific enough yet to know whether the antibody in your blood is to the SARS-CoV-2. There are other coronaviruses. You might have been exposed to another coronavirus. It is the common cold. The other thing is, even if you had antibodies, we don't know if those antibodies would be effective against COVID-19. The best antibodies to have would be neutralizing antibodies. So having a test that says you have some antibodies to a coronavirus doesn't necessarily mean you had COVID or that it would be protective. Now, having said that, I don't want to be discouraging because the test, there's a lot of people working on developing this test. The best way to know if you had coronavirus, and the test is laborious, but it can be done, is to take your serum and mix it with SARS-CoV-2 and then put it in a culture plate with epithelial cells, like in the back of your nose. We can culture them, and we can look to see if the virus can infect those cells. If we just add virus to cells like that, we see the virus growing and we see something called plaques. The cells die in lice. If I mixed serum with virus and put it on that plate of cells and I inhibited it, I would be very, very sure that you had SARS-CoV-2 in the past and that you are protected. That test cannot be done in any kind of high volume way, and it is very dangerous and risky for the researchers, and lab medicine would never be able to do that in any kind of clinical way.
Absolutely. Just for comparison, we recently crossed the threshold where we have performed 50,000 molecular tests, the earlier tests that Serpil described. There is no way we could even come close to approaching the numbers that would be needed in the neutralizing antibody test that Serpil described.
I appreciate the thoroughness of you describing that, because as we have people listening and engaged about getting back to work and try this new normal, the new normal is not test and what I'm hearing from both of you is that a test does not allow you just get back to the good old days. That the test alone is first of all, it's hard to get, and we have to prioritize our testing capabilities, and the importance of really the social distancing, the masking, the practices that we've put in place for our communities. Is that fair to say that as people are trying to get back to a new normal, the new normal has to be a way in which we prioritize testing, but also our healthy habits? Lisa, could you comment on that?
Yeah, I think that's very much fair, Laura. I think that one of the risks of using an antibody test that isn't a test of neutralizing antibody is then I begin to believe I'm immune and perhaps are less vigilant at my social distancing practices, my hand hygiene, wearing a mask, and in becoming less vigilant, very much put myself and my loved ones at risk because I believe I'm immune, and in fact, I'm not.
So a question that has come in is, how important is an early diagnosis? So does it help in recovery? So just as we talked about prioritized testing, I think there are some people who are also concerned in, if I know early enough, will that help in my recovery? Dr. Azan, the pulmonologist in you, I'm going to turn to you.
Right. So it's like any disease. Patients come to us ideally and really normally when they're symptomatic.
Mm-hmm.
So a lot depends on how symptomatic you become. You've heard that this disease can be pretty mild. People can have it, not feel that bad, and not report to a doctor. We usually do see those patients who are symptomatic, as Lisa noted, calling in, reporting to their doctor, getting tested. We know the history, natural course of the virus itself over 2 weeks, the relative progression, and the severity of the disease that can occur at about 5 to 7 days into the disease. There's no evidence that I know of that early testing prevents any of the disease that we've seen in terms of recovery or having severe COVID. What would be important for testing if you suspect you have COVID is to get tested as soon as possible, again, so you avoid spreading it and can quarantine and get the care you need, and so that we could backtrace who you might have exposed. So that's the purpose of testing.
Well, and I think that's a great segue as we think about the new normal and the back to work. So as you talked about symptoms, I think that's important as everyone is thinking about, even if it's going back to work or even going to the grocery store. If you are feeling, and can you describe the symptoms so that people understand what that could look like and what they should do?
Yeah, the symptoms are, in most patients, very similar to what you would experience with other upper respiratory viral infections, including influenza, cough, shortness of breath if it becomes more severe, fever, fatigue, body aches. Those are the more common symptoms. As more cases were described and reported, it became clear that some patients do have additional symptoms like gastrointestinal manifestations, diarrhea, rashes, and other uncommon things, but most patients will present with malaise, cough, fever, chills, fatigue, shortness of breath. Those are the most common manifestations.
So again, as we think about, so if one important rule here I'm hearing is if you're having the symptom, please seek care and your care provider. But are there other aspects to prevention that our listeners and employers should be thinking about for their employees and for their families? Dr. Ezra, you want to?
Oh, okay. So things to do that might be preventive.
Yes.
So we've talked about everybody's masking, the cloth masks, cleaning the area in which you work with the cleansers that would destroy the virus, washing your hands. Probably the best prevention is washing your hands with simple soap and water. Being safe distance from those around you. And that's the 6 feet away from everyone rule. And just being careful in how you do your work every day, being mindful of, again, not having meetings with large groups of people, even with the mask on.
Mm-hmm.
So these are all the ways that would be preventive, very preventive against any virus. And in addition, of course, keeping healthy, eating the right things. I always tell people that exercise, good nutrition, rest, those are all very important to your immune system and help you battle any kind of infection.
Thank you. And Dr. Urian, you've been helping our employers and working with Dr. Merlino on getting Cleveland Clinic at work, both for the Cleveland Clinic and for other corporate entities. Anything else you'd want to contribute, or things that you've seen as continuous improvement of this process that have been helpful?
Yeah. So when we think about helping other organizations, I'll just share that we advise others to do exactly the same things that we are doing ourselves. Mm-hmm. And as you think about each of these preventive measures, think about them as each being imperfect. There was a model described by a PhD, James Reason, called the Swiss cheese model. And he described multiple layers of prevention as each being imperfect, a lot like a slice of Swiss cheese. It will have holes in it. But when you put together a whole block of Swiss cheese, if you put in place multiple preventive measures, a mask, hand washing, social distancing, layer after layer, you end up creating an effective barrier because those holes don't align. And so both within the workplace here in our own facilities and our own work, and as we go out and engage others, we really encourage people to think about these as layers of additional protection, none of which is 100% perfect. Our masks aren't perfect. Hand washing isn't perfect. The 6 foot distance, none of these is going to be 100% preventative, but as you layer on additional layers, you're going to get layer and layer and layer of protection, and those holes are not going to align. So overall, you're going to reduce your risk. Screening for symptoms is a really important component. We do ask people who are feeling ill not to come to work, and many organizations have put into place provisions to make it more feasible for people to do this. We ask people not to come to work if they're experiencing symptoms. And then us and many organizations have chosen to put into place temperature screenings. Mm-hmm. So as a person enters the facility, they will have their temperature taken, or there'll be a scanner that takes their temperature. And if they have a fever, they're of course not permitted to enter.
Well, and that's one of the wonderful things that you and your team have been working with, is looking at those different layers. So we've talked a lot about masking, but there's face shields, there's gloves, there's other components, again, other layers, other filters. Do you want to talk about any of the aspects or the impact of those based on the work environment? I guess that we see in the grocery store and other places, different tools being utilized.
So cloth masks are very commonly used applied tool, and like the other layers, it's not a perfect tool, but it is a tool that helps provide a layer of protection. We advise the double layered mask, cloth masks. They should be snug, but not uncomfortable. And of course, you have to keep them on. So they should be covering your nose and your mouth. Sometimes we see people with it pulled up or pulled down or hanging around their neck as a necklace. Those are all holes. Sorry, don't provide any good cheese for us. But really using the mask effectively, using it consistently, and doing good hand hygiene, washing your hands with soap and water, scrubbing for at least 20 seconds with the soap, or if you don't have access to soap and water, using the hand sanitizer with alcohol to sanitize your hands before you put the mask on and after you take the mask off. And as an employer or a place of business, providing both a place and a signal to your employees or to your customers that this is what the expectation is. So having a table, posting a sign, providing masks if you are able, providing hand sanitizer to make it very clear that in this place we intend to be safe and to treat each other respectfully. Me wearing a mask in many ways protects my colleague, my friend, my customer, my client, as much as them wearing one protects me. And so it's really creating an environment of protection where everybody understands that we're doing everything we can to keep everybody safe.
Thank you. You know, we've also read a lot and seen people sanitizing surfaces. Dr. Ezram, you commented on that, you know, at the grocery store, or taking products and wiping them down. We've also recently heard about UV lighting being used as a disinfectant. I don't know, can you comment on that, Dr. Ezra?
Right, we did a lot of research on ultraviolet light for sterilization of surfaces. This is an old technology. It's extremely effective, particularly with the new UV lights. You can sterilize surfaces or materials within minutes. So the UV radiation that comes from the sun has sterilizing properties, but most of the nucleic acid damaging UV light that comes from the sun is blocked actually by our atmosphere, which is beneficial to us because we are all living things that have nucleic acids. But for the virus, if we have the damaging UV lights in specific light bulbs, it can destroy all nucleic acids on the surface of materials within minutes. And it's something that we use in our biosafety laboratories, where we'll turn on the UV lights when we leave for the day, knowing that everything there will be done in the morning.
In terms of scale of it seems like that could be highly effective.
It is highly effective. Yes, it is. You wouldn't want people in there at the time, obviously, but
yes,
yes, when things are closed down.
Great.
The virus does degrade over time. And so routine cleaning is appropriate for things that are not touched very often. So if you have a room or space that nobody's been in for 7 days, then that is certainly something that routine cleaning would be adequate for. But if you have high touch surfaces, doorknobs, handles, chairs, tables, things that are getting a lot of touch, then the disinfectant cleaning much more frequently is recommended.
Yeah, one of the practices I've seen, even here at the Cleveland Clinic, is the environmental safety crew coming through and really wiping down on almost an hourly basis the door handles, the safety of our facility. And again, it's a great lesson for other people to model, of wiping down those common areas, those common surfaces. Can be quite impactful. A question has come in, and curious, maybe Dr. Ezram, we've heard a lot about herd immunity, and maybe with the loosening of some of the regulations, what's the reality of developing herd immunity in COVID-19?
Herd immunity refers to the fact that when you introduce a new microbe, in this case SARS-CoV-2, into a population, the global population in this case, it's a new virus. No human being had seen it before. It started in Wuhan. And for the most part, the virus has had a great day because nobody had immunity. It was completely fertile ground for it to infect and infect others. And as it infects more and more people, and we develop convalescent antibodies, there will be increasingly less people for it to infect. So the herd immunity is when you have enough people who have had the virus or a vaccine and no longer able to be infected. It's another, I love the Swiss cheese model, another block. So I might have seen 5 people in the last 3 days, and that would be a lot for me these days, seeing 5 people in the last 3 days personally, face to face. But if 2 of those had antibodies, either because they've had the virus or they were vaccinated, you can see the spread of the virus would be hampered. The virus no longer has this wonderful buffet upon which to feast and go from person to person. it stopped.
Mhm. And well, and you mentioned the people getting the virus. I'm curious, have we seen people immune after they get the virus then, or they have the ability to also get it again?
That's a question I get and I discuss often with our pathology colleagues, particularly Dr. Kadkota, who's an expert on this in immunology. And there I will point to the fact that our human race for millennia have encountered microbes. Some of course, much worse than this, the flu pandemic in 1918, 19, and 20. In general, the human race is very good at building immunity. We have survived, and we have survived because we do develop immunity. There is evidence that people that recover do have neutralizing antibodies. That means they can't get it again. Some people don't develop very high titers of antibodies. Even they, if they saw it again, would have a memory response. Their body would be prepared. I saw it before, I'm seeing it again. Boost the immune system quickly. Finally, there might be people for some intrinsic purpose, immune compromise, perhaps on medication, or for some disease that they have, where they can't develop a good immune response. Those people would be particularly susceptible to the virus, but then possibly again. I think the best evidence, and I always say this, that immunity does occur is the convalescent sera that the Red Cross is running through a Mayo Clinic study, where I can take serum from somebody who's recovered, provide it to somebody very sick, and offer the opportunity to provide passively that immunity that that individual who recovered developed.
That's interesting. Dr. Urin, I see you shaking your head. Thoughts on that response?
Fascinating and very well explained, Dr. Saran. Yeah, I think herd immunity is an epidemiologic concept that we learned about years ago and really haven't had the opportunity to think about or apply very often. I think right now in our communities, we're nowhere near the level of having herd immunity. So in order, basically what we need to do to have herd immunity is to have enough people who are immune or not able to be infected either because they had the virus or because they had a vaccine, that you break the chain. So if you think about the virus spreading, it's basically a chain of people. I spread it to you, you spread it to somebody else, you spread it to somebody else. Herd immunity means that there are enough people who can't get it to break that chain. And it requires a whole lot more people to be immune than what we have currently. So even though conceptually, yes, absolutely, we want to drive towards that, we're not close.
I know some numbers I've heard that herd immunity requires 40% of the population to have immunoglobulins. We are nowhere near that, even in New York or Boston. I'm not sure in China, and certainly not in Cleveland. So we don't want 40% of people to get this virus. This is why we're aiming for a vaccine. It's the same reason we have influenza vaccines every year.
Which is a great segue to the other popular question of where do we stand with vaccine development?
That's right.
Well, vaccine development is a 20th and 21st century phenomenon. We didn't really have a vaccine. Polio was one of the first, and then flu in the 40s. They've changed our lives. If you think of the polio vaccine, the influenza vaccine, these things killed millions or disabled millions. Our antiviral capacity as a human race, yeah, we can develop herd immunity, but quite a high cost. And what we discovered is we could develop immunity without getting sick if we took pieces or parts of that virus, injected it into you. Then your body's immune system would see the pieces and parts of that virus without getting infected, would recognize that they're not part of you and develop immunity. That's what we do every year with the flu. We have to do it every year with the flu because it changes enough that the immunity you had last year is not recognizable this year. That usually takes a long time because we have to grow the virus, usually in chicken eggs. We need a lot of chicken eggs. And it usually takes 1.5 to 2 years. Now, Methodology for making vaccines has, thank God, improved over the last 5 years, really, recently. And we now can take nucleic acid, either the RNA, like the virus, this virus has, or make it into DNA, like we have. And instead of giving you pieces and parts of the virus, we can give you the nucleic acid. Okay, it's not the infection. It's what encodes the pieces and parts of the virus. We don't have to give you the entire thing, just some of the specific pieces of the virus. We inject it. Actually, your cells make those pieces of the virus, but not the whole virus. We're not giving you everything to make the whole virus, just certain pieces that we want your body to make antibodies to. Once it's injected into you and you make those proteins that are on the virus, you develop immunity, and it looks just like the immunity you would have from the whole virus. So there's so many companies working on this. This new technology means that it's months, not years, to a vaccine. Really exciting press releases just in the last week.
Yes. Okay.
Very exciting. Not just, remember, there's two kinds of antibodies. You can bind the virus piece or you can neutralize it. The best ones are neutralizing antibodies. The preliminary data suggests these vaccines do lead to neutralizing antibodies. And I'm very excited about that because that's what we need.
Great answer. Here's another one from about business and a return to work. The current protocol of record for employees who have been in proximity to someone who has tested COVID positive is that we're asking them to stay home for 14 days. Now that testing is more available, should we pivot into having them tested, or can you give, or have them return to work in a different protocol? So Lisa, Dr. Urian, I'm going to ask you to respond.
Yeah, it's a great question. I would say there are no clear
Complicated.
guidelines yet. One of the, I think, challenging questions would be, we don't know how quickly you, if you were exposed, are going to develop sufficient virus to be detectable when we put that swab deep into the back of your throat. So we would have to do studies to understand when typically, so still it would probably take a few days, I think on average,
Yes.
5 is to develop symptoms, that you would have enough virus to actually be detectable. Because what we don't want to do is to bring you in, do the test, and have what we call a false negative. So we get a negative result because there wasn't enough virus present to detect it on the molecular test. And then you think you're safe, we think you're safe, and then you go out and expose others. So I think that you're looking at a minimum at best of 5 days to be able to do the test. Depending on your laboratory, it's going to be at least the next day before you typically get results in an outpatient setting. And so we're just not really set up to do that yet. And you're already about halfway to your 14-day turnaround. So I'd say it's possible that in the future, as we have more and more testing available and have more and more detailed data with research like Serpil and our colleagues are doing, that we might have more clarity. But right now, I don't think we're prepared to offer that.
And it sounds, if we talk, going back to the theme of the new normal, it seems like the new normal is that it's evolving, and that what we know today is actually probably going to look different tomorrow or a week from today. So the access to testing, we're seeing a lot of home kits for testing and other aspects for testing. So it sounds like, really for everyone to continue to their health habits, but to continue to pay attention into the environment of what's out there, and what we're saying is the appropriate. So another question came in of, if I am, and I think they're looking for real specifics here of, if I do feel sick or if I feel like I have been exposed, what should I do?
Call your healthcare provider.
That's the question.
Call your healthcare provider. If you don't have one, go to Express Care Online, Cleveland Clinic Express Care Online, and we'd be happy to help. I think you're right about the pace of progress. And I think that can be very exciting. It is certainly energizing to see the focus, the teamwork, the collaboration that has enabled us to really learn and respond to the virus much, much, much more quickly than we've responded to many challenges in the past. That's very heartening. But I think, you know, the flip side is that requires us to constantly be vigilant and paying attention to the most recent and accurate information. And that as preliminary data come out, we have to understand that these are preliminary data, and we have to keep following to see how it pans out over time. So I don't think this is something where we're going to, okay, now I understand COVID virus. I think it's more like, I understand up-to-date information on COVID virus today, but in a day, in a couple of days, there could be new emerging information that could really change our picture. So we really have to be nimble.
Since we are, again, living with COVID, a question has come in about, are there things, again, in that preventative space, things that we could actively be doing to boost our immune systems? Vitamins, nutrients, other aspects to your diet. We've seen a lot of things out there recently about your immune system and boosting your immune system. Would either of you like to comment on that?
So I can start to say, in general, wellness, make sure you get plenty of rest, make sure you stay well hydrated, make sure you're getting exercise, make sure that you and your team have a way to handle the stress that comes with this abundant change, the illness, the worry that comes with it. We also have had trials looking at some specific vitamins, and I'm wondering if Serpil would want to comment on those.
Right, so there is some evidence, good evidence-based data, that vitamin D in particular is important for your immune status and for antiviral immunity. So vitamin D is particularly always important when you're living in the Northeast where there's very little sunshine. So you can make your own vitamin D, but in the absence of a lot of sunlight, and if you're indoors all the time, you're often deficient in vitamin D. It's something easy to do over the counter and would help in many ways. The others are vitamin A and zinc. We do have a trial on vitamin A and zinc together for people who have been diagnosed with COVID and that are not asymptomatic, but outpatients. So they're feeling well enough, they're on we put them on vitamin A and zinc in a trial. Oh, it's a great trial. We've enrolled a number of people. We'll have outcomes from that soon. Having said that, zinc inhibits the coronavirus replication. That was shown for the SARS, the MERS. This virus too will be inhibited by zinc. And so it's not a bad idea. You can get the zinc lozenges. They taste pretty bad, but you could get those at the pharmacy over the counter too. And I know some people are using those.
Great. You know, as we wrap up here too in the new normal, I'd love your closing thoughts. Dr. Urin, I'll start with you. As we return to work, as we return to what our family lives, our community lives, your advice and your thoughts about the new normal for everyone.
Yeah, it's a great question. I think my thoughts are really about keeping yourself, your loved ones, and your community safe. So as we look at the preventive measures we've talked about, part of it is, how do I protect myself? But a lot of it is, how am I protecting those people around me? And I think of it in terms of teamwork. So if each of us is protecting, each other by using our own hand washing, by using our own masks, by using our own distancing, it's sort of a team effort to keep everybody safe and protected. And I think that's really what it's going to take to keep everybody as safe and healthy as possible. It's not a bunch of individuals who are keeping themselves protected and isolated. It's a bunch of individuals working together very closely to protect themselves, so they're not a carrier to infect somebody else, but also to protect each other. I also think that it has been a fantastic reminder of how powerful it is when we are focused and aligned around a common cause. And I mentioned earlier the teamwork and collaboration that we're seeing as different individuals, different departments, different organizations are coming together to tackle this. I think it's actually quite inspiring to see and experience. And I'm hopeful that we're able to carry that forward as we go into the new normal in terms of both our ability to focus and act quickly, also thoughtfully, and to be extremely collaborative as we tackle new challenges.
I love your, the phrase out there that we have out on posters is, we're in this together. And truly we're in this together, not just as the Cleveland Clinic and our community and our partners and our employers, that as we work together, everyone has a role in really being a part of the solution here. So I wonderful sentiment. Dr. Ezram, you know, as we think and look at loosening the restrictions, I think everyone is anticipating potentially another surge or a surge in the fall. So how do we coexist in a new normal with, I think, what might be people expressing as anxiety or an anticipation of the future? Can you comment on that?
I think that is one of the biggest fears that people have when I speak to them, that the virus is here. It's still here. We have cases ongoing, not the surge we expected, but the virus is here. And as the fall comes, it's not the virus gets any worse or more aggressive. It's what Lisa was speaking to, and that is we tend in the summer to be outdoors, more open spaces, spaced apart. It's the same for influenza. Influenza is here all year long, but really accelerates in the fall as we go into buildings. It's cold, we're in more confined spaces, and we're closer together than in the summer. So the idea that there might be another peak of this virus in the fall is based on good public health and epidemiology data that's what happens with every virus, flu, RSV, paraflu. Yes, we'll have more viruses, all viruses in the fall. Maybe we'll have a vaccine, but in any case, we know we can be effective against this virus with the methodologies we've been speaking about. You know, I have never been so inspired by my team and my colleagues here, and really all of Cleveland and the state of Ohio. We can do anything. I mean, we know how to deal with this now. We're ready. So I don't think that we want to be oblivious, but on the other hand, just smart, right? Do what we're doing and continue that. And meanwhile, hopefully we get a vaccine.
Well, you certainly, and the clinic has certainly done that with the new Center for Global and Emerging Pathogens to not only look at COVID-19, but other pandemics and other potential harmful pathogens. So I think, you know, this was something that you and your colleagues sought to look to set up in the fall before we even knew the words COVID-19. And here we are. Can you just, as we conclude, talk about the center? And I think it is a ray of hope in this new normal that we have people dedicating their lives and their work to looking at this problem.
Well, Laura, thank you. First of all, I have to credit our CEO, Dr. Mihaljevic. He saw it. Bill Gates saw it. You watched one of his YouTube videos from 3 years ago. It's pretty scary to hear him talk about this and predict it. The number one thing globally that can hurt the human race, everybody understands now, are viruses. And we recognized that, almost 3 years ago. We started on this journey knowing that we needed to do just what we're doing now, virus research. And so we set up the center. We've recruited Dr. Jay Jung, who is one of the top coronavirus researchers in the world, but also Zika and dengue and flu. And in fact, Zika and dengue both had outbreaks in Florida over the last 5 years, which is what really propelled me. And perhaps our listeners can look up Zika. I have 2 daughters, and this was one of the reasons. Zika can affect the fetus if you're a pregnant woman. And it's on mainland USA. And Jay actually studies that as well as coronavirus. And so these are virus infections that can affect all of us, any walk of life. And we need to do research on them. The Cleveland Clinic needs to do research on them. And I'm so glad we have Dr. Jung coming in the center. Let me just say, Dr. Jung is working on a vaccine, and he can do the assay for the neutralizing antibody I was speaking to. We're setting that up here in a biosafety level 3 laboratory now. And this is something we can all be proud of.
Well, we certainly are proud of both of you for joining us and the work that you continue to do, and thanking everyone for joining us today. We are in this together, and as a nonprofit entity, we appreciate everyone's support. Your support 100% does have an impact here, supporting the good work of continuous improvement, clinical transformation, and research. So thank you, Dr. Ezram, Dr. Yerian. We truly appreciate your insights. And for those of you on the call today, thank you. If you do have any questions regarding your health or would like to connect with a healthcare provider, please visit clevelandclinic.org. This site has the latest COVID-19 updates and other valuable information. The Cleveland Clinic is committed to helping employers get back to work safely, and you'll find industry-specific guides, those for restaurants, manufacturing, and other resources online at clevelandclinic.org/COVID-19 at work. Lastly, we need your help. The Cleveland Clinic's ongoing response to COVID-19. Please feel free to visit us at give.ccf.org/COVID-19 and learn how your gift can support some of the research and other aspects we talked about today that will have an immediate and impactful difference. Thank you for listening today. Until next time, take good care of yourself and each other. I'm Laura Kalafaitis, Chair of the Philanthropy Institute at Cleveland Clinic. Be well, stay resilient, and thank you.